My name is Angie Ganchoso and I'm from Catholic University of Guayaquil. I'm in the fourth cycle of the career of medicine. Today I'm going to speak about Ustekinumab as an induction and maintenance therapy for Crohn's disease. Ustekinumab is a fully human IgG1 monoclonal antibody which blocks the biological activity of interleukin-12 and interleukin-23 by inhibiting receptors for these two cytokines which help activate certain T cells so that they subsequently cannot bind to their receptors.
There are a number of treatment options for patients, but unfortunately not all patients respond. The first line of treatment for patients with Crohn's disease is typically steroids, drugs like prednisone. Sometimes we use immune suppressive drugs like azathioprine or mercaptopurine or methotrexate. And then there's a group of drugs that we call biologic drugs, and they're the ones we've used up until now are targeted towards a particular protein called tumor necrosis factor, or TNF. So we've talked about these anti-TNF biologic drugs. The ones we use in practice in patients with Crohn's disease today are Remicade, Humira, and Cimzia. About two-thirds of patients will have a clinical response to those TNF blockers, and about one-third of patients will have a remission. And then amongst the patients who respond, if you follow them over the course of a year, half or more of those patients will end up losing response or becoming intolerant to the drug. So there's quite a large group of patients who either don't respond to the TNF inhibitors at all, or they initially respond, but then they lose response. And so, those are the patients where there is a need for new therapies. So our study looked at another biotechnology drug called Ustekinumab, or Stelara, that targets a different protein in the body besides TNF. So it's not a TNF blocker. It blocks two other proteins called interleukin-12 and interleukin-23, which seem to be important in driving the inflammation of Crohn's disease. And so the idea is when you give Ustekinumab that you can block those proteins, and that will then drive down the inflammation of Crohn's. There were two phases to the study. The first phase was looking to induce response in patients who had active Crohn's disease in spite of having been treated with the TNF blocker. And we tested three different doses of intravenous Ustekinumab as compared to placebo. And then we looked to see amongst the patients who responded to Ustekinumab, if you continued Ustekinumab, and we were dosing those patients every 8 weeks, was continuing Ustekinumab as a maintenance treatment among the patients who responded to it, was that more effective than placebo over the next 6 months or so of therapy. And what we found was that Ustekinumab given intravenously was more effective than placebo for making patients better or inducing clinical response. And then when you followed those patients who responded to Ustekinumab, if they continued Ustekinumab, they were more likely to be in remission after about 6 months of therapy than if patients stopped Ustekinumab.
Applications in medicine. Ustekinumab is now approved by the FDA for treatment of adults with moderate to severe Crohn's disease who fail or could not tolerate immunomodulators or corticosteroids and never failed treatment with TNF blocker or who failed or were intolerant to TNF blockers. There are other uses, like they are indicated for adults with active psoriasis arthritis alone or in combination with methotrexate, and is also indicated for the treatment of adult patients with moderate to severe plaque psoriasis who are candidates for phototherapy or systemic therapy, diabetes mellitus type 1, and biliary cirrhosis. Ustekinumab is used as an orphan drug, which is a pharmaceutical method to treat rare medical conditions. The pros are that the improvements are noticeable as early as 3 weeks and is broadly accessible and affordable for patients. The cons are that these include side effects like respiratory, like nasopharyngitis, upper respiratory tract infections, or pharyngeal pain, and nervous systems like headache, dizziness, and others as fatigue, In the gastrointestinal system, like diarrhea and nausea, and the musculoskeletal, like back pain, myalgia, arthralgia, local as injection site trauma, pain, bruising, and irritation, dermatologic like pruritus, and psychiatric like depression. It also includes immunological side effects like infection, and it also can create antibodies to this drug.
Chronic inflammation in IBD and how anti-TNF therapy works. The immune system is composed of a network of cells that work together to defend the body against infections and disease. Cells in the immune system can cause inflammation to eliminate an infection in the body. Once the infection has been cleared, the immune defenses begin to wind down and switch off until the next infection signals them to switch back on. One theory is that the immune system does not respond to the body's off switch in people with inflammatory bowel disease, IBD, leading to an overactive immune system and chronic inflammation in the gut. This chronic inflammation is spurred on by a large imbalance of chemicals called cytokines, which act as on signals to cause inflammation. Another theory of IBD is that the immune system is constantly being stimulated and therefore is always in an activated state, although the cause is not known. One of the major signals of inflammation is a cytokine known as tumor necrosis factor alpha, or TNF alpha, which is produced by some cells of the immune system. When TNF alpha is released from cells, it interacts with other cells through TNF receptors on the surface of those cells, which results in inflammation. This inflammation contributes to the development and persistence of the ulcers in the gut that cause the symptoms of IBD. Controlling inflammation is critical to maintaining good health, improving quality of life, and reducing the chance of needing surgery. One way to reduce inflammation is by modifying or suppressing the immune system through medications. Medications that modify the normal response of the immune system are called immunomodulators, and those that specifically target and suppress the effects of TNF alpha are known as anti-TNF agents. Anti-TNF agents are part of a class of medications known as biologic therapies. Modifying or suppressing the immune system can restore balance in the system and therefore prevent ongoing damage. Reducing the amount of TNF alpha that is circulating in the blood is associated with the reduction of inflammation in IBD and improvement in the disease symptoms. Anti-TNF medications work by attaching to free-floating TNF alpha outside of cells, as well as transmembrane TNF alpha found on the cell surface. Because it is attached to the anti-TNF medication, TNF alpha is unable to interact with its receptors on the surface of cells in the gut to cause inflammation. Examples of anti-TNF medications used in IBD include infliximab, adalimumab, and certolizumab pegol. These drugs have each shown to be effective in reducing signs and symptoms of inflammation in Crohn's disease and ulcerative colitis. In fact, inflammation and ulcers can be healed within a few weeks in some patients taking anti-TNF therapy. By binding to TNF alpha, these medications can reduce inflammation in the gut caused by TNF alpha. Some patients greatly benefit from anti-TNF therapy. Regular treatment with some anti-TNF agents may reduce the number of hospitalizations by half and decrease the number of surgeries in patients with Crohn's disease and ulcerative colitis. However, as with any medication, it is important to understand the side effects. The most common risk of anti-TNF therapy is losing response to the drug, which can happen in as many as 50% of patients after 1 year of treatment. There are a variety of ways to prevent loss of response, but one of the most important is staying on a regular schedule of infusions. In this animation, we have reviewed how anti-TNF therapy works. However, There are many other therapies in development that target additional molecules involved in inflammation.
Usually supplied in Ecuador, Crohn's disease is more frequent in developed countries, with an increase in its incidence in recent times. It is chronic and autoimmune. It means it can affect any part of the gastrointestinal tract, most commonly the ileum.
What is Crohn's disease? Crohn's disease is a chronic condition characterized by inflammation in the gastrointestinal or GI tract, which is also known as the digestive tract. Since Crohn's disease is a chronic illness, it is persistent and will be present throughout a patient's life. However, patients and physicians can work together to manage the symptoms of this disease. The GI tract includes the mouth, esophagus, stomach, small intestine, large intestine, and anal region. Crohn's disease can affect any part of the GI tract, but the most common location is the last part of the small intestine, which is called the ileum, and the first portion of the colon, which is also referred to as the large intestine. Current thinking is that Crohn's disease is a genetic disease caused by abnormal regulation of the immune system. The GI tract is frequently confronted with bacteria from our diet and environment. Many factors can contribute to a person's risk of having Crohn's disease, but most can be thought of in three categories: genetic predisposition, environmental factors, and a dysregulated immune response in the GI tract, which causes inflammation. Environmental factors that may contribute to Crohn's disease include infections, smoking, and taking antibiotics or anti-inflammatory drugs known as non-steroidal anti-inflammatory drugs, or NSAIDs. One way that the body can protect against potential bacterial threats is with inflammation. We are familiar with how inflammation looks on the outside of the body, for example, when you have a scrape or a cut. That scrape or cut becomes red and inflamed as a result of the immune system trying to get rid of any bacteria and viruses that are in the wound. After a few days, when the immune system has finished its job, it turns off, so the redness and inflammation disappear. In Crohn's disease, inflammation, ulcers, appear within the GI tract, and the immune system works to combat the bacteria and viruses in the same way as with a cut on the surface of the skin. However, the difference is that the immune system is not able to turn itself off after it has gotten rid of the bacteria or virus, so the ulcers remain until they are treated with medicine or surgery. This chronic inflammation is what causes the symptoms of Crohn's disease. The symptoms of Crohn's disease vary depending on where the disease is located and its severity. This means that every patient with Crohn's disease experiences the disease differently. Most patients with Crohn's disease have abdominal pain and diarrhea. Other symptoms related to the GI tract can include abdominal tenderness, loss of appetite, weight loss, fever, fatigue, rectal bleeding, anal skin tags, and ulcers. In children, Crohn's disease may result in stunted growth and a failure to thrive, even if GI symptoms are not present. In addition to symptoms involving the GI tract, Crohn's disease can affect other parts of the body. Symptoms outside of the GI tract can include joint pain, liver inflammation, osteoporosis, skin problems, eye problems, mouth ulcers, and anemia. Patients with Crohn's disease should expect to lead normal lives in consultation with their healthcare providers. The goal of the healthcare provider is to help people manage Crohn's disease, rather than having the disease manage them.
In conclusion, Crohn's disease is a complex condition to treat, and not all therapies work for every patient. The FDA approval of Stelara Ustekinumab represents an important advancement in treating patients with Crohn's disease, as this therapy offers an alternate mechanism of action to induce and maintain clinical remission over time. Thank you.